It's my pleasure to welcome you to this PQI Innovation webinar titled Race, Racism, and Perinatal Health Inequities. My name is Kaylee Espinola, and I'll be running the Zoom logistics of this webinar and introducing today's speakers. When I'm not providing tech support for PQI, I'm a senior project manager for the Massachusetts State Perinatal Quality Collaborative. A couple of housekeeping items before we get started. This webinar is being recorded and will be posted for free on the PQI website. There will be time for questions at the end of the presentation. Please type any questions you have into the chat and we will address them during the Q&A portion. If you have any technical issues during today's webinar, please feel free to send me a private message. Now it's my pleasure to introduce today's keynote speaker. Dr. Veronica Barcelona has earned her BSN from the University of Michigan, her MSN MPH from Johns Hopkins University, and her PhD from the Tulane University School of Public Health and Tropical Medicine. Her NIH-funded research interrogates mechanisms and risk factors underlying adverse pregnancy outcomes, with the goal of achieving healthy and safe birth outcomes for all. And now I'd like to turn it over to Dr. Deborah Bingham, who is the CEO and founder of the Institute for Perinatal Quality Improvement. Thank you for listening and enjoy the webinar.
Good day, everyone. Nice to be with you all today. I'm really excited to have Dr. Barcelona give her presentation, and I'm also honored to be able to give an update from PQI and having both Kaylee and Renee Byfield as PQI team members here. And I also saw another PQI team member, Dan Bingham, has joined as well. So glad to be with everyone. The Institute for Perinatal Quality Improvement, which I am the founder of, was founded with the mission to expand the use of improvement science to eliminate preventable perinatal morbidity and mortality and end perinatal racial and ethnic disparities. And so today's topic is extremely relevant to this mission. And before I start the webinar, before we hear from Dr. Barcelona, I want to just go over a few updates from PQI, as I usually do. But today my update will be a little more personal because today is 9/11, and my thoughts on this day of remembrance is for me both as very personal as it is for many people in the country. So on 24 years ago today, I was working as the director of maternal child health nursing with over 7 units under my responsibility in 2 different hospitals in New York City. I see Zola on the call and Renee. We were all working together in New York City at the same hospital on the same team. I was at a meeting downtown with other nursing leaders. I was just a few blocks from the World Trade Center when our beepers started going off, pagers started going off, that planes had flown into the Twin Towers. Without many words said, actually, I don't remember people really saying much. We all gathered our things very efficiently and very urgently, and we immediately left the room and to get back to the hospitals that we were responsible for running. And we began our emergency, implementing our emergency preparedness plans. By the afternoon, as we had worked so hard discharging anyone who could be discharged to make room for all of the casualties that we had planned on seeing. It struck me that we weren't seeing as many casualties as we thought because people either walked away or they died. What I remembered on that day, and as I reflected on it further, is how hate kills and love generates. growth, and creativity. And so my life changed because of that. And I will never forget the flyers with the photos of loved ones posted on the bus stations and walls all over New York City. I'll never forget the smells of burning for days and months. I'll never forget also the long lines of people volunteering to give blood, coming to the hospital to volunteer to give blood and to just be of service. I'll never forget all the kindnesses that I saw. In fact, I think the city became more kind than ever. Again, love generates and hate kills. And again, 4 years ago, my beloved son died today. Sorry, I didn't expect to be quite as emotional at the very beginning, but it's hard stuff. He died due to disinvestment in infrastructure. He is only one of countless other individuals who suffer or die due to structural constraints on their health, because people of color suffer a disproportionate amount of injuries and death. He died because he fell through some rusted out stairs at a public transit station in Boston area. In the United States, infant mortality rates are some of the highest in the developed world. Infant mortality is the death of an infant before his or her first birthday. So my pain is not unique to me. There are many families in the United States who are suffering from the tragic, painful loss of their infant children. Infant mortality rates by race and ethnicity remind us of how inequities are experienced throughout our country. People with darker skins than mine, people with different race ethnicities, like Black and Hispanic, people with darker skin, or indigenous people, their children die at higher rates than those of white people. In fact, recently, Mississippi is a state that my son did research in, and Mississippi recently declared, as recent as August of 2025, just a few weeks ago, declared a public health emergency on infant mortality. And as you can see on the bottom graph, there is a disproportionate number of Black non-Hispanic infants who died, 15.2 per 1,000 live births, compared to 5.8 per 1,000 live births. In the United States, our pregnancy-related mortality ratios have climbed. The pandemic led to even more, but even before the pandemic, we saw a rise in maternal pregnancy-related mortality rates. When we look by race and ethnicity, we see the same story. Non-Hispanic Black, non-Hispanic American Indian or Alaska Native mothers die, more mothers die in pregnancy-related causes than white and non-Hispanic women, or women of all other races and ethnicities. 80% of these pregnancy-related deaths were preventable, according to analysis from the maternal mortality review committees. 80%. Most recently, This data were published about 2018 and 2022 pregnancy-related deaths, and I want to draw your attention to the last sentence in their abstract. During 2018 to 2022, 2,679 pregnancy-related deaths could have been prevented if the national rate was reduced to the lowest state rate. Again, these preventable deaths, all of these families in the United States suffering from preventable deaths. Many of the women who died had other children who are left to be raised without their mothers. When we compare our country, our states within our country, we see that there are states where pregnancy-related mortality ratios are much higher than other states. But that doesn't leave any one of us off the hook in this important public health crisis. All of us have a role to play in eliminating preventable pregnancy-related deaths. And deaths are only the tip of the iceberg. We see that there has been almost a 200% increase in severe maternal morbidity in the United States. How one fares in the United States has been characterized by a racial division that begins at birth with disparities in healthcare. Now, we at PQI, at the Institute for Perinatal Quality Improvement, have been working. We came up with many solutions and many programs to help address this crisis in our country. We now are so proud, and Renee's the director of the Speak Up program, and we are so proud that we have 1,856 Speak Up champions, and you can join us too. We have upcoming Speak Up Champion Conference, and our program is different. We include QI. We use QI methods and tools in order to help us be able to all more effectively work to eliminate preventable perinatal deaths and injuries, and in particular, perinatal inequities in our country. We also have released the birth equity modules. It's a whole course with 4 different modules. We are offering, I'm very excited to say, 2 more webinars this year. And we have very esteemed speakers. One is Carol Sukala, and she'll be talking about transforming maternal health model that has been released and funded by the Centers for Medicaid and Medicare Services, a blueprint for maternity care. And Amy Romano and Lila Foreman and Rebecca Skye will be talking about an innovative program called Step Up Together, which helps with integrating community birth professionals with hospital-based professionals. Also, I'm very, very pleased to let you all know that my son's book, he had a book under peer review at the time of his death. This book was released in December of 2024, and we have launched a website, and as well as there are other, and the websites are on this slide. And he goes in this book, he talks about structural constraints on health, and is a book that is valuable for all health professionals. And as health professionals and public health leaders, I know that we're all working to create ripples of hope. And I'm going to read this quote from Senator Robert F. Kennedy Sr., which talks, where the title of my son's book was inspired by. Each time a man, and I would say a woman, stands up for an ideal or acts to improve the lot of others, he sends forth a tiny ripple of hope. those ripples build a current which can sweep down the mightiest walls of oppression and resistance. So our ripples of hope are what can bring down any wall, the mightiest walls of oppression and resistance. We created a video. This is an introductory video, and and you would end this video, 4 of the people he identified as ripples of hope in his book are highlighted, as well as my own personal journey in releasing this book into the world. And again, we are, and as we shift to give the time over to Dr. Barcelona, I want to leave us with this thought from my son, and I'm going to have Renee read it for me. Thank you.
Thank you, Deborah. Thank you for all the work that you're doing to push these agendas forward to Deborah, and we thank you for having such an amazing son. And in his honor, I'm going to read a quote from his book, Ripples of Hope. The more time I spent in Mississippi, the more I came to appreciate that the Delta is not an outlier in the American landscape, but that the dynamics of race and class have epitomized what is happening in the rest of the country. I came to better understand that racism is more than bad people intentionally harming someone else they view as inferior. It can take that form, but it is also people, sometimes including me, who believe they are not racist, but who are unable to acknowledge or unwilling to change the systems that structurally benefit them while disadvantaging others. The more time I spent in Mississippi, the more I was able to see the same inequities and racism in my own community.
Thank you, Renee. And I will say that you all showing up today, being willing to scrutinize and learn how to stand up and change the systems that are oppressing others. I'm very, very encouraged by you coming today. And I look forward to our conversation. We'll have time after Dr. Barcelona's presentation for Q&A. So I'll turn it over to Veronica now.
Okay, thank you, Deborah. And I really appreciate that really heartfelt and grounding presentation introduction that I think underscores the gravity of what we're talking about here today. So I appreciate the opportunity to present my research. So the objectives of my talk today are to describe how racism explains disparities in perinatal health outcomes, define stigmatizing language and how it may result in harm to marginalized people in healthcare settings, and to identify ways to change potentially harmful words, policies, and practices to reduce health inequities through patient-centered, respectful language. Next slide. So if you ask any woman or pregnant person in the United States what their birth story is, you'll get a range of responses. Many will include stories of mistreatment, pain, not being believed, or feeling unheard. But if you ask a Black woman, you will often hear even more heart-wrenching stories. In sharing my program of research with people in the community, I've received a range of responses, including stories of friends who died as a result of pregnancy or childbirth, and their symptoms were ignored. Others share their own personal stories of complications and suffering. The unifying thread in all of these stories is that they are largely preventable. Keeping all pregnant people healthy and thriving as they start or expand their families is my why. And the documentary Aftershock does an excellent job of summarizing many of the issues I'll describe today that inform my research, and I highly recommend it if you haven't seen it yet. Next slide. So As Deborah described earlier, Black and Native American women have had higher rates of nearly all adverse pregnancy and birth outcomes for decades. When we look at the relatively rare outcome of mortality, we observe significantly higher rates of death related to pregnancy and childbirth among Black and American Indian, Alaskan Native women. These gaps have not changed over time and continue today. About 700 women in the US die each year as a result of pregnancy or its complications. And American Indian, Alaskan Native, and Black women are 2 to 3 times more likely to die of pregnancy-related causes than white women. And these trends have continued through the most recent data, with a statistically significant increase in deaths for Black women in 2021 to 69.9 deaths per 100,000 live births. Next slide. And if we look a little closer, here we can see that with increasing levels of education, white individuals have lower mortality. However, with increasing education, Black individuals continue to have high mortality. And when we look at people with a college education or higher, Black individuals are 5 times more likely to die as a result of pregnancy or childbirth than white people. Again, now, recent studies are saying as high as 87% of these deaths are preventable. Next slide. So click for me, please. There's some animations here. So just one at a time. So why do Black birthing people have worse outcomes? Much of the epidemiologic literature on this question can be summarized into 2 main camps. First, mother blame. Black individuals have worse pregnancy-related health outcomes, including preterm birth, cesarean birth, pregnancy-related death, gestational diabetes, and pre-pregnancy hypertension. Mother blaming puts the responsibility solely on the individual's behaviors. However, this does not explain the bulk of the risk for these outcomes. Click, please. Yep. And click again. Next, blaming socioeconomic status. Black birthing people are more likely to have less education, lower income, and to be publicly insured than white individuals. Low socioeconomic status contributes to limited access to preventive services to control chronic illnesses, which can lead to more adverse pregnancy outcomes. However, Black birthing people with higher socioeconomic status still have worse outcomes when compared to white women with lower socioeconomic status. Click. And click again. So in recent years, systemic racism, including both interpersonal and structural racism, have been suggested as the true causes of racial disparities in perinatal health. Next slide. Racism permeates all aspects of society in the United States, and medicine and nursing reflect that. Increasingly, studying and publishing on the effects of racism and discrimination has become more acceptable. Especially in the last 5 to 10 years, the number of articles published examining the effects of racism on preterm birth and other adverse birth outcomes has increased significantly. Click for me, please. Thank you. Research has documented an increased risk of poor perinatal outcomes when women experience individual level or personally mediated racism and discrimination. There's also a growing body of research on structural racism and pregnancy and birth outcomes. Next slide. In recent years, there's also been more qualitative work published that describes the effects of racism in obstetric care. Black women who experience racism and discrimination have fewer clinician-patient interactions than white women, receive poorer quality of care, and report a lack of autonomy, poor communication, and feeling unheard. Next. Therefore, it's necessary to examine the adverse and unequal biological outcomes of pregnancy within a social and environmental lens. Bronfenbrenner's socio-ecological model posits that the individual's health is affected on many levels in family, community, and society. Again, racism permeates all aspects of society in the United States, and examples applying this model can be seen here. You can click, please. On this public policy or structural level, we have employer-based health insurance and an unequal judicial system. Next. We also have a lack of parental leave, which is a policy decision. Next. Redlining and segregation at the community level. Next. And at the organizational or hospital level, we have hospital policies and mistreatment that is institutionalized. Next slide, sorry. At the interpersonal level, clinician bias. And finally, at the individual level, mistrust of the healthcare system. And my research addresses several of the levels in this model. So I really wanted to get at institutional systems that reinforce racism and bias with this project. In this study, we examined electronic health records of all pregnant people greater than 20 weeks gestation who were admitted for labor and birth from 2017 to 2019 at 2 hospitals in New York. Building off work done in internal medicine settings, we use machine learning methods to examine stigmatizing language documented by clinicians in the electronic health records of birthing people. Next. So what is stigmatizing language? It's language that communicates unintended meanings that can perpetuate socially constructed power dynamics and result in bias. Next. It's been associated with poorer quality of care, especially for people racialized as Black or Latino. Next. And differential care may contribute to disparities in morbidity and mortality outcomes. Next. Negative language has also been hypothesized to spread implicit bias as subsequent clinicians read what was previously charted. Next. So we implemented new methods to measure bias and discrimination in this study, specifically using natural language processing. So NLP is a type of machine learning that allows us to look at large amounts of free text and analyze it quickly for our outcome of interest. It's only recently been applied to stigmatizing language studies. In 2022, we published a review of studies examining stigmatizing language in clinical documentation, identifying only 9 articles where definitions of stigmatizing language varied and NLP was used in 4 studies. Studies included varying clinician groups from physicians, nurse practitioners, midwives, social workers, pharmacists, and nurses. And none had examined stigmatizing language used specifically in OB settings. Next. So the aims of this study are shown here. So the first was to refine and compare natural language processing approaches to identify stigmatizing language in clinical notes. Aim 2 was to apply the NLP system to examine patterns of stigmatizing language use by patient race and ethnicity. And aim 3 was to examine stigmatizing language and pregnancy-related morbidity. So for the first aim, oh, sorry, can you go back? Yeah, for the first aim, we did qualitative work to define stigmatizing language categories for the obstetric setting, and we reviewed about 2,000 notes. For aims 2 and 3, we looked at the full complement of notes for about 19,000 patients over the 3-year period, resulting in about 300,000 notes. And this is why you want to automate it and use machine learning and not do this by hand. The pregnancy-related morbidity outcomes that we looked at included cesarean birth, hemorrhage, and infection. And we hypothesized that Black and Latino birthing people would have more stigmatizing language in their notes and more pregnancy-related morbidity than white patients. And the purpose of this study really was to examine the systems that have bias built into clinical care and to reimagine and create new ones. Next slide. So in order to develop an automated algorithm to identify phrases and words that could be stigmatizing in obstetric notes, we had to conduct human annotation of narrative notes. Our research team of nurses and data scientists qualitatively reviewed over 1,700 notes, looking for categories of stigmatizing language that have been previously identified in the literature. Examples of such categories included the weaponized use of quotations, or the use of quotations to highlight unsophisticated patient language. And this can contribute to mistrust if it's read by patients in their own electronic health record. Questioning patient credibility. The patient says X, but the chart says Y. Failure language may influence how the patients see themselves in labor and the ability to birth the way they want. difficult patient language, for example, non-compliance or the patient refuses an intervention, and disease first language, such as the diabetic in room 3. Here are the results. Oh, next slide. Next. Yep. Here are the results of our first qualitative analysis of the notes. We reviewed 1,117 notes from the 2017 birth admission. The most frequently identified language categories were disapproval and questioning patient credibility. We also identified and named a new category, power and privilege language. Stigmatizing language was the most frequently identified. Next. In birth admission triage notes, and least frequently identified in social work initial assessments. Next slide. We were then invited to write a commentary in obstetrics and gynecology, which you can read here by scanning the QR code with your phone. In this paper, we build on relationship-centered care and reproductive justice frameworks to describe how language used in written documentation, verbal communication, and behaviors can contribute to perinatal inequities. We adapted the power wheel to depict marginalized identities and power privilege language that may be recorded in the notes of birthing people. We suggest here that stigmatizing language encompasses all of these identities, reflecting characteristics or traits that are preferred or more desirable in our US culture. For example, in order to marginalize birthing people, you have to define who has privilege. The use of language in clinical notes that is not essential to care may in fact change clinician behaviors and affect patient outcomes. We provide examples in this article of preferred language, as well as interventions on the institutional, community, and societal levels to promote equal language use with the objective of improving maternal health outcomes. I'll share some of our recommendations later in the talk. And you can see here on this power and privilege wheel that some of the identities that we identified that were specific to obstetrics include citizenship, skin color, formal education, gender, body size, language, a whole bunch of different identities. And, you know, just knowing people, none of us have all of the privileged nor marginalized identities, right? We contain multitudes, each of us. But the idea of marginalizing for certain characteristics means that everyone can be harmed by this. So improving or reducing or eliminating harmful or stigmatizing language will improve outcomes for everybody. Next slide. So here are some examples of marginalizing language that we found in the notes. She claims she's in abdominal pain. The patient states her baby was quote unquote born dead. The patient adamantly declined weekly testing and attempted to provide type 1 diabetes education. However, the patient refused. These examples suggest disbelief of patient reports. They express disbelief of the patient reasoning or self-care by race or social class. They may portray the patient as difficult or emphasize clinician authority over the patient. Next. We also found examples of power and privilege language, underscoring that language signals social status or preferred characteristics for birthing people. And such examples included the patient and spouse planned to hire a nanny after the birth. The patient was easy to engage, thought process was logical and linear. Patient reports a 9-year nurturing marriage with husband who works as a financial analyst for a prominent bank. And husband is a neurosurgeon. Next. And yep. So based on these examples, annotated and identified by our research team, we trained and developed a well-performing algorithm to identify stigmatizing language in electronic health records. Next. Our findings are published here, and our algorithm performed well and was able to identify stigmatizing language on the sentence level, pushing the field forward as previous published analyses largely operated on the word level. And in the qualitative analysis of notes, we expected to find this language. We know there are poor outcomes, but again, we're looking for systemic reasons why. And the objective of this project was not to label individual clinicians or call them out for use of this language, but to identify, to educate, and to look at the broader systems that support the use of this language. We also wanted to replicate and find new categories and themes of stigmatizing language to train our algorithms, which we did. Next. And there's a paper we published on it. Next. Okay. So now I'll present the results of our analyses. And this is for the analysis specifically looking at the use of stigmatizing language by patient race and ethnicity. We published this paper last year in JAMA Network Open. In our sample of over 18,000 births, 59% identified as Hispanic. Next. Most were between 20 and 34 years old. Next. Unmarried. Next. And insured by Medicaid. About 40% of the sample, next, preferred to speak another language other than English. And finally, next, about 73% had a vaginal birth. Also, nearly 90% of the births were full term. So this was largely a pretty young and healthy population. Next. Here you can see the results of regression models examining the presence of any stigmatizing or positive language in the charts of Black patients. These are odds ratios and 95% confidence intervals for the 3 statistical models and forest plots. We found that Black patients were significantly more likely to have stigmatizing language documented in their medical records compared to white patients. Model 1 shows the unadjusted associations of race predicting stigmatizing language use. We then adjusted for potential confounders in Model 2, including maternal age, marital status, insurance type, and preferred spoken language. The association still held. Then we controlled for birth characteristics in Model 3, including parity, mode of birth, gestational age, as well as race, ethnicity, and demographics. As we hypothesized, Black patients were more likely to have stigmatizing language documented, and this is in line with previous work. Next. Interestingly, we found that Black patients were also more likely to have positive language documented. And this includes words like the patient elects or chooses or opts, right? Painting the patient in a nicer way and really documenting a patient-centered approach to care and how you're documenting. We hypothesized that this could be used to having a variety, or this could be due to having a variety of clinicians documenting in the records, and perhaps some providers documenting positive language as a result of anti-racism or bias training, while others were still documenting language reflecting societal and individual biases by race. We did not find significant associations for patients identifying as Asian or Pacific Islanders or Hispanic. Next. Here are the findings for some of the language categories among only Hispanic patients, where you'll see there was an increase. Oh, next slide, sorry. Oh, maybe I took out the Hispanic slide. Oh, no, there it is. Sorry. Could you go back a slide, please? All right. So here we examined findings by language category. Here you can see the findings for Black patients, where there were some slight increases noted if patients identified as Black by stigmatizing language category. And the next slide, please. For Hispanic patients, we also found that power and privilege language was actually less likely to be documented among Hispanic patients. So that goes along with our hypothesis as well. Okay, next slide. For the final study aim, we examined associations between stigmatizing language and 3 pregnancy-related morbidity outcomes. These outcomes were chosen because they're potentially preventable and contribute to severe morbidity and mortality. Here's a diagram showing how we determined our cases for this study. We excluded stillbirths, and then we defined each outcome separately. We define low-risk cesarean in two ways, using both the Society for Maternal Fetal Medicine and NTSV definitions. SMFM is defined as term, singleton, vertex, live births with no prior cesarean births and no high-risk diagnoses. NTSV is for nulliparous, term, singleton, and vertex presentations. Hemorrhage was defined using ICD-10 diagnostic codes and included any blood transfusion, peripartum hysterectomy, use of an intrauterine balloon tamponade device, or estimated blood loss exceeding 1,000 milliliters. And finally, chorioamnionitis is an infection of the membrane surrounding the fetus and amniotic fluid, typically caused by bacteria. It was identified in the records through relevant ICD-10 diagnostic codes. Next. So we use binomial multivariable logistic regression to examine the associations between stigmatizing language and low-risk cesarean birth. And this analysis is in press right now at Health Equity. We found that patients with any stigmatizing language, and especially language representing the difficult patient and unilateral authoritarian decisions category, had significantly higher odds of having a cesarean birth, using both SMFM and NTSV definitions. Here you can see increases in the risk or association of the odds of cesarean birth ranging from 18 to 46% higher if you had stigmatizing language documented. Next slide. Similarly, for chorioamnionitis, people with any stigmatizing language documented had a 23% higher odds of having this infection. If you had difficult patient language documented, you had a 33% higher odds. Next. And similarly for postpartum hemorrhage, we found, for example, twice the risk of having a postpartum hemorrhage if you had difficult patient language documented. Next. We also found interaction effects. So for looking at the interaction between any stigmatizing language and the patient being identified as Black, they were 4 times more likely to have a low-risk cesarean birth. Hispanic patients that had stigmatizing language documented were almost 8 times more likely to have a postpartum hemorrhage. And the interaction between any stigmatizing language and being insured by Medicaid, what resulted in a 6 times increased risk of chorioamnionitis. Next. So we have some clinical recommendations based on this work to share. We also recognize that stigmatizing language is nuanced and depends a lot on the context. So some of the language we found that can be avoided is failure speak. So instead of documenting failure to progress in labor, state the dilation over the number of hours. Next. Next, yep, you can focus on the positive. Next. Instead of referring to a person as geriatric or advanced maternal age, next, simply state the patient age. Next, the use of words such as refuses, claims, complains may label the patient as difficult. Instead, next, use words like the patient endorses, states, or opts not to. Next. We recommend avoiding demographic descriptors that may contribute to marginalization, such as unmarried woman presents for birth. Instead, use a strength-based narrative. Ask the patient's pronoun, address them as parent, or use their name. Next. We recommend against documenting patients' race and ethnicity in their patient description or as a risk factor, because racism is the risk factor. Race and ethnicity are not biological contributors to disease. Next. We also recommend avoiding disease-first language. Next. And to use patient-centered, strength-based language instead. Finally, it's important to note that instead of elective abortion, the preferred language is induced abortion. Next. So in summary, stigmatizing language is a marker of clinician bias. We showed here that there are differences in its use by maternal race and ethnicity, and that it's associated with morbidity outcomes. There are lots of steps we can take to address this marker, beginning with clinician education and training about more neutral documentation. Our lab has also been working on evaluating the use of ChatGPT to identify stigmatizing language in real time and rephrasing it with more neutral terms. EPIC is piloting 2 initiatives this year with select hospitals to offer more neutral language in real time and to review narrative notes when prompted for the presence of stigmatizing language. Also, we're conducting analyses to reach specific medical and nursing disciplines and have papers under review looking at associations between stigmatizing language and obesity, substance use, maternal disability status, and postpartum pain. Next. I also hope that this work will be used by hospitals as a quality improvement metric and to examine the uneven application of hospital policies at the unit level. Next. We also have a new R01 grant from NIH that was recently funded, which will expand this project to include more clinician details and will involve community members. We will build on previous work in this grant to include more maternal outcomes and neonatal health outcomes. Finally, we hope this work is replicated in other geographic areas where different language and cultural contexts exist locally. Next. So my vision for my research is that all women and pregnant people will welcome their baby in an environment of respect, care, and love. This is not a unique vision statement made by me. Many cultures view birth as a sacred event, and our Indigenous leaders believe that you do not have to be perfect to be deserving of love, respect, and safety. Therefore, I see this project as an attempt to mitigate harm, but it does not go far enough. We must promote wellness and honor the making of each new family. Every person who's a parent here or loves a child knows that we only want our children to be surrounded by love their whole lives, and that begins at birth. Next. I'd like to acknowledge my team, co-investigators, data scientists, nurses, physicians, my fabulous data manager, pre-docs, postdocs, volunteers, and mentors, of course. Next. And then here's a picture of my team, part of my team, and I acknowledge my funders as well. So thank you, and I'm excited to engage in conversation with you all.
Yeah, thank you very much. I think this is such important research, and we are so happy at PQI to be able to highlight your work. And I do see that Kat put a question in the chat, says, do you look at the impact of substance use disorders on presence of stigmatizing language?
Yeah, thanks for that question. So actually, most of the literature that's been published in the last 5 years on stigmatizing language has originated in substance use and addiction treatment settings. So I think because mental health substance use has been very stigmatized in our medical system, in our culture, in our country, they've really spearheaded that work. And there's been a lot of guidelines and articles published on stigmatizing language in that group. We just recently submitted a paper where we did find an increased frequency of stigmatizing language in the notes of patients admitted for labor and birth, so perinatal patients. We see the same things, that where there's, for example, the uneven application of hospital policies that screen for substance use. That's where this comes in this setting, right? So yes, we do have a paper that's been written about that and should be coming out in the next few months.
That's exciting. Any other questions, please put them in chat. While you're doing that, I thought it was really a very important recommendation about not talking about somebody's race or ethnicity in the note. I also think when we are presenting for maternal morbidity and mortality review, that should not be the first thing that gets said, right? Of course, race ethnicity needs to be recorded for QI purposes, but it isn't relevant to how the patient outcomes are being reviewed. And sometimes that can bias how somebody interprets that case. So I think even in not only in your charting, but in your case reviews and in your maternal morbidity and mortality discussions. I see a couple of other questions came in. Tiffany, hi Tiffany. Veronica, you are hitting all the major issues. Thank you for saying what many others refuse to say. And so thank you, Tiffany, for that comment. And if you have any questions, please put them in the chat. Amy Valencia asked, these data are so compelling. Can you share a bit more about the time it took to build the machine learning aspect of chart mining?
You sure can, Amy. Thanks for that question. So, I'm a public health nurse, maternal child public health nurse, and a perinatal epidemiologist. So I had to partner with folks that were experts in data science and machine learning. And it was very humbling to sit back and just learn from them as they led the way. Pretty much, this was a 3-year project. The first year and a half was really extracting the notes, going through all the administrative red tapes to first download all that data from the hospital. And then to clean it all up, there's lots of coding that has to be done to get rid of HTML and things. And then once we clean the data, it was processing it, getting the qualitative part done. I never thought as a epidemiologist, as a hardcore quantitative person, that I'd be publishing so many qualitative papers. But, qualitative papers are wonderful. They really provide all the rich content that makes the story come alive, I think, of any data set. So it took us about 1.5 years to do all of that work to begin with. And then we were able to start saying, okay, now let's look at the race ethnicity analysis. And for that, we had a lot of missing data and ended up doing various multiple imputation techniques using, I think we used both geographic location and zip code and surname matching to predict race and ethnicity for the full sample. We ended up doing that for about 60% of our sample and found that it was a very accurate way of determining race and ethnicity. So that was also another step that we had to do. Once we completed that, then we had to really carefully pick out, using ICD-10 codes, and all of our morbidity outcomes and confounders. So, it was a long process. I was very happy to get to the end where we could finally do the analyses and look at the morbidity outcomes, because for me, that was the whole goal of the project, but it was a long road to get there.
Very long. It sounds like a very long road. And I like the partnership aspect, because that's also an important part of any QI initiative, right? It's also an important part of research. So we don't have to have all the answers, and getting a great team with us. There is a question that came in from Catherine, and she asked about future funding based on changes at NIH. If you want to make a comment about that. But more importantly, I also, as important, I think the question about replicating this in South Carolina, I think other people might be wondering if they could replicate this at their institutions. I mean, I know that's one of your goals, and I don't know what the best way for people to move forward in that regard is. But first about the funding, and then how to replicate.
Sure. So yeah, we have a new NIH grant. It's over $2 million now to continue this work and extend it, to include both clinician and community advisory boards. We're including neonatal outcomes. We're looking at more clinician characteristics, like who documented which things, so we can identify how people are taught, how norms for documentation are established, and how they can be changed. So this in this current NIH funding environment, it had a really great score. It should have gotten funded in January when it was reviewed at the council level, which is the final review step before grants typically get funded. It sat there until about a couple weeks ago, and we just found out we got funding. So, for right now, we're able to continue to do this work. We changed some of the language to focus on documentation patterns and less on words that might get flagged by the NIH. But we're really excited to have this continued support to continue this really important work. In terms of replication, I think that, we've been really intent on publishing all of our methods. So we have several papers out there. And if you'd like to, Catherine, reach out to me. I'm happy to share any papers you'd like to read. We have all of our methods published. And would be happy to give a talk to your group in South Carolina as well to talk more about some of them.
But if a hospital wanted to hire you to come in and help them set up a system for analyzing their charts, is that a possibility as well? Maybe not necessarily you per se, but is there a way to spread this set up already?
Yeah, actually, Rose Horton was one of my mentors on this project. This was funded by the Betty Irene Moore program. And Rose and I are working with some other folks on putting together a package that we can market to hospitals individually so they can implement this work. And, what I imagine is, like, those of you that are clinical nurses and you use Epic, you see dashboards where it says how many people received this bundle, this AIM bundle, this postpartum hemorrhage bundle, whatever. Like, one day I would love to see a QI person come up with a way to have stigmatizing language built into that dashboard as a quality metric. So you could say, even without using these fancy methods that we used here, you could do a review of, a sample of 50 charts or 100 charts. And you could say, did we find any of this language? And then, set a metric that you want, less than 5% of your charts every month to have any of this language documented. So, just some thoughts, but there is some work in this space coming. And I think that Epic also is rolling out some tools that, should be available to everyone at the hospital level to kind of both push out reminders or flags about stigmatizing language when you prompt it, and also passively identify when people are writing notes. So I think these things are coming as more and more awareness is being built.
Yeah, I love the idea of the chart review as a place to get started. You don't have to wait for this package deal. And Tiffany Montgomery says they're already doing this work in their maternal program that she manages, because those papers are available, and those that language of what to look for is out there. Somebody asked about whether there is an educational program that you recommend that helps train people, helps give people the education around stigmatizing language. I will say that we do, the entire Speak Up program is based on language and thinking about how we talk and how what we say actually affects not only what we chart, but what we speak actually affects outcomes. So that program is definitely based on a communications approach to improving and communications, as well as our modules. And we will be adding some additional modules around the work you've done, Veronica, because I think it's so important to even dig even deeper in this work and really point to your findings. And if you could, yeah, is there any other education that you're aware of besides the PQIs things and stuff coming, or is there anything out there already that you would recommend?
Yeah, we're coming up with a program. We're developing one with Rose, like I mentioned. So that's in the early stages of development.
And then there's a question about, do you know if organizations like ACOG are working, have a work group to look at changing some of this terminology in pregnancy, change terms like geriatric pregnancy. Like going to the organizational level, like the professional organizations, to get some of the language changed, get the language changed there that then trickles down, right? I love that question, Jennifer.
Yeah. I have presented, Rose and I presented last year at A1. And I think that's really important. We haven't done it yet, but we have, obstetric clinicians on our team that are helping to disseminate this work. And so I think absolutely that's one of the next steps.
Well, and we are at the hour, and I appreciate all the questions that people had. I appreciate your time. If you would just hang on, we're for a quick debrief, and then everyone else, I would just love to thank you again for coming. And as you move through the world, creating ripples of hope, thank you so much for all the work you're doing, taking care of yourselves and others, and all the best.